Good evening, everybody. Thank you for joining us. It looks like we've got lots of you here now, and we're all set up at our end, so we'll get things underway. My name's Ollie Coburn. It's a pleasure to welcome you to the latest injury rehab network in partnership with Steroplast. Just a little bit of housekeeping before we get going. Please feel free to introduce yourself in the chat box. It's always great to see who we've got with us. We will be sending certificates of attendance, as always, for your CPD folders. So if you're joining us live, you'll get one of those tomorrow and we'll email it to you. Please be patient with us. You'll also get a recording of tonight's session that you'll be able to access via a link. The presentation this evening will be about 30 to 40 minutes, there or thereabouts, and we'll, as usual, follow that with a Q&A. For the Q&A, you should be able to see the button at the bottom of your screen, or if you're on your phone, just tap and it'll pop up. Post your questions in there for us rather than in the chat box. And if you could just have a read of what's already been posted before you do put a question in, somebody might have already asked what you were thinking. If they have done that, you can upvote it and give it a thumbs up. We'll, of course, ask the most popular questions as we get to the end of the session. For any that we miss, we will direct you for ways that you can contact Bill afterwards if you've got any really burning questions. Quick note on BASRAT, for those of you who don't know us and are joining us for the first time, we're a professional association and we're the regulator for sport rehabilitators in the UK. We've been running these webinars now, both in combination with Steroplast and on our own, as an addition to the rest of our work since the start of the pandemic. If you would like to support our work, you can become an associate member and you can contact us afterwards about that. The benefits of being an associate member are listed there. That's enough from me. That's the housekeeping. I'll pass you to Andrew Watson from Steroplast, who's our host this evening, and he will introduce our guest speaker.
Thanks, Ollie. Evening, everyone. Thank you very much for joining. It's great to see so many people. Appreciate life is getting busy again, so really great that everyone's found the time to listen. And I've no doubt that's because we have another excellent speaker with Professor Bill Ribbans. I'll let Bill introduce himself shortly, but just a quick introduction to Steroplast before we hand over to Bill. So Steroplast Healthcare have over 25 years experience in the medical and healthcare sector, and we work in sport providing all of the tapes and first aid and emergency items that sports teams and physios and sports rehabilitators might need. We've been working with BASRAT, as Ollie said, on the injury rehab network events, and these events started in 2019, where we were running them on a face-to-face basis at our offices in Manchester. And since then, with COVID, we've been able to bring them online with the support of BASRAT, which has been great. And usually the form of the event is that we have a guest speaker who talks on a particular topic, and then we facilitate some networking. Obviously, the networking side is a bit more of a challenge at the moment, but the online events have proved to be really popular, and we do hope to start delivering some more face-to-face events in the near future when we can do that safely. Ollie, can you just move it on, please? Some of the events that we've got planned this year are just listed here, and we've been really pleased that following the interest in Len Funk's presentation about shoulder injuries in March, that we've now got an expert panel together for a shoulder injuries question and answer event on the 26th of May. And joining Len on that panel is Doug Jones from Altis Healthcare and Ethan Stamp from Sale Sharks. So that's another great event, and all the details are on our website if you'd like to get involved. That'll be followed by Angela Jackson, who'll be talking about developing younger athletes, and then some of the other events that we've got over the summer are also listed there. We're also working on plans and in discussion with lots of other excellent potential guest speakers for events next year. So that's it for me. Thanks again for joining, and thank you very much, Bill, for your time. If you haven't already looked this up, I'd highly recommend Bill's book, Knife in the Fast Lane. I've managed to find the time to read a good bit of it, but it's a brilliant history into sports medicine, insight into the life of a surgeon, and also sort of doesn't shy away from some of the politics in sport, so tackles women's sport, the kind of the boundaries of professionalism in sports medicine and some other interesting issues. So I'd really recommend Bill's book, and the proceeds are supporting Prostate Cancer UK as well. So hopefully I'll encourage a few more of you to enjoy reading it. But yeah, thanks very much, Bill. Thanks, Ollie, and thanks everyone for joining. I'll hand over to Bill now.
Thanks very much, Andrew, and a good evening to everybody. And thank you very much to Basrat and Steroplast for asking me. I was very sorry when I got the invitation to that I wasn't going to be able to be live in Manchester, but we kind of understand that we've learned to use this media for education and disseminating information, and it's an enormous pleasure. As I saw people coming online to see that, you know, they're coming from not only the UK but around the world. So it's delightful to be with you all. Ollie, can I need to bring my slides up, don't I? Do I need to share screen? Right. As Andrew said, I'm an orthopedic surgeon, and I started off my consultant career working in central London at the Royal Free, but I've spent the last 25 years back in my hometown in Northampton. I first got involved in elite sport as a doctor in 1981. So I've just completed my 40 years, and I really want to commit myself to paper. I actually ceased to be a surgeon a week ago, and now I'm getting used to being an orthopedic physician and sports physician. The subject that I've been asked to talk about is the athletic ankle, and in particular, when do lax ligaments need surgery? I'm aware that there's probably very few surgeons online, and most of you involved in the rehabilitation and management conservatively of these injuries. So I've tried not to make it too surgical, but I have just got one animation video of surgery in there, which I hope you'll find of interest. The way I've organised the ligament lecture is, over the course of the next 30 to 40 minutes, is to try and cover the four main ligaments around the ankle and the hindfoot. The lateral ankle ligament that we're all probably familiar with, the low ankle sprain as it's called, syndesmotic injuries, the high ankle sprain, and then those problems which are slightly rarer, more difficult to diagnose on the medial side, deltoid and spring ligaments. So I just want really to talk to you about the anatomy, talk a little bit about the epidemiology, the way injuries occur, the assessment. I've concentrated more on the last three ligaments because I think most people are familiar with how to examine and classify lateral ligament injuries, and then what our management options are, with the emphasis on when do you think that this patient's going to need surgery. We know that ankle injury is a major problem in sport. In something like a quarter to a third of all sports, ankle injuries are the number one injury. And not surprisingly, 3/4 of it involves the lateral ligament complex. Overall in sport, it's ankle ligament injuries combined probably represent about 40% of all athletic injuries. And because of the nature of our patients wanting to go back to sport, whereas the general population have probably got a 1 in 3 chance of sustaining a further similar injury, our athletes have probably got a 3 out of 4 chance in the next 3 years of re-injuring themselves. So the role of our rehabilitation specialists and our surgeons working together is absolutely essential for our athletic population. And I'm not just talking about Olympic and world champions, but obviously kind of our weekend warriors as well. I've just put in, if you can just bear with me, just 2 kind of biological slides, or you might call it pseudobiology. What happens when our ligaments get torn? Well, we know in that first 10 days that it's going to induce an acute inflammatory response. And during that time, we'll get bleeding, which we'll see it often under the skin. And into that hematoma will be important factors coming in that are going to help healing. Over the course of the next 6 to 8 weeks, if everything goes properly, we'll then start to get some early healing, what's called the proliferative phase. And then during that time, new blood vessels will come in. They will bring cells and growth factors, which are all important, and they'll begin to form this primitive collagen and matrix forming into the gap caused by the ligament injury. And then going out for anything up to over a year, we'll get remodeling and maturation. And what we hope during that time is that the immature collagen and its matrix will start to resemble something like normal. But remember, after a significant ligament injury, what you've really got is fully remodeled scar tissue. It is functionally different. So as a surgeon, will not usually see patients in this early stage unless I'm pitch side, which I often am at the weekends. But we know that your role is you're going to be trying to minimize the bleeding and the swelling, apart from that important bleeding that we'll get in the gap. We want to avoid making the injury worse. As we go through that 6 to 8 weeks, what we're looking for eventually is type 1 collagen. What we don't want our patients to be doing is going too early on those ankle ligament injuries and getting the weaker type 3 formation that will make it susceptible to ligament elongation. And then going forward, as we get our patients back into sport, we need to carefully control those mechanical stresses and to try and promote correct collagen alignment. Well, how does our ligament regain strength? There's not an awful lot out there, but I think this is a reasonable shot. On the left here, you'll see that the biomechanical strength of an anterior talofibular ligament in an adult is about 160 newtons. Clearly, if you rupture it and you get a grade 3 injury, then it's going to have very little strength. In the first week or two, it will start to rebuild strength, but when you get to about 3 to 4 weeks, that's the danger time for your ligaments. As those new blood vessels coming in, it actually reduces in strength. And I don't know what you all see in your practices, but I often see the athlete come in perhaps 6 months down the line, and the history is, oh, I sprained my ankle, it all seemed to settle down. I went back to play 3 or 4 weeks later and went over on it again. That's the danger time. At the 6-week stage, which you might say, well, we're hopefully going to get our patients back, you've still only got about 2/3 of strength. And it will take anything up to a year and beyond before it will get back to something like normal strength. So I just want you to bear that in mind. Well, let's start with lateral ligaments. So when to operate. This picture is Leonard Brostrom. And as most of you will know, the most common lateral ligament repair is some form of Brostrom repair. This is an interesting guy. He was a Stockholm surgeon. 5 years ago, in 2016, the Swedish Foot and Ankle Society asked me to go and give a lecture on where are we with the Brostrom 50 years later. It was interesting. The Swedes knew very little about Brostrom, and we actually had quite a problem even trying to find this photograph. But this is your man. This is the guy that produced this paper on a Brostrom repair that is still going 55 years later. Now, just to remind ourselves of the anatomy, this is a cadaver dissection, and this is the beautiful anatomy that is the lateral ligament. This is the anterior talofibular ligament here. It usually is in 2 parts, as you can see. It's usually about 25 millimeters long from the tip of the fibula to the talus, the non-articular part. Here's the lateral wall of the talus. This is the posterior facet of the subtalar joint. This is the calcaneofibular joint. This is the talocalcaneal ligament, which we forget about. These are our perineal tendons, and these are branches of our sural nerves. And the piece that is reflected there is the inferior extensor retinaculum, which we'll come and talk about. So we don't often see it like that, but I thought it's a beautiful specimen. Now, I was asked a couple of years ago, what's the likelihood of you spraining your ankle and finishing up on a surgeon's table? Well, in the United Kingdom, I've worked out that we have something like 1.8 million ankle sprains a year. Now, over 80% do not finish up in casualty. They will present to our physiotherapy clinics, to our GPs, or they'll self-care. About 300,000 people a year come to accident and emergency. We tend to think they're all going to get better in 6 weeks, but as you see from this paper, it suggested that up to 3 years, the bottom numbers, 15% will still have some problems of either pain, lack of confidence, instability. So the best scenario is there's about 250,000 people in the UK sustaining new ligament injuries every year that they're going to finish up with chronic symptoms. From casualty numbers, about 14% are regarded as severe. So there's 42,000, let's say, bad grade 3 injuries pitching up in casualty. So what's the estimate? Well, I tried to do the back of a fag packet calculation on how many people finish up with surgery. There's 2,000 orthopedic surgeons in the UK, not enough. There's only about 1 in 8 will actually perform a brostrum because everybody else is busy doing hip and knee and replacements and hand surgery and spines and children. And surgeons always think they do more surgery than they really do. And I think some people will do 30 or 40 a year, some people do 1 or 2. So I think there's probably only about 2,500 brostrums done in this country a year. So that means that about 6% of severe ankles finish up with surgery. And of the total people who sprain their ankles, I think you've got about a 1 in 700 chance of needing an operation. Before we go on to surgery, let's just have a look at the optimal conservative management. And a bit like surgery, robust scientific evidence is still lacking in certain areas. But the evidence is there that supports, as I'm sure all of you know, is that a phased functional program in combination with early RICE is very important. And that, of course, neuromuscular training at the appropriate moment should support that rehabilitation. There is evidence that the early use of some anti-inflammatories and some homeopathic medications such as Traumeel may well be helpful. And interestingly, PRP and viscosupplementation injections in small series have been shown to speed up recovery. There's also evidence that in grade 1 to 2 sprains that a semi-rigid brace in the early weeks is helpful. And in the more severe sprain, the short period of immobilization in something like an air walker or something like that, followed by semi-rigid brace, helps recovery. And we all know that when we've got our athletes back, to minimize resprain, they need to continue with their prophylactic bracing probably and balance training. So what about the timing? If we're going to start operating on patients and we accept there's not going to be that many, should we be doing it almost straight away, as soon as they've had their MRI within a week? Should we be doing it at 6-8 weeks, or should we be doing it electively? Jon Carlson is a Swedish surgeon. I've been over to watch him operate, beautiful surgeon, one of the leading exponents in Europe. He said 15 years ago that functional management is still the most favorable strategy for acute lateral ligament injuries. Well, if we're going to do early surgery, are there problems? Well, there is. If we started operating on every lateral ankle sprain, we would completely kill the budget of the national health system. It's technically more difficult. I think, as you can imagine, that trying to stitch together lateral ligaments is a bit like blotting paper or wet tissues, and it has a higher complication rate than delayed surgery. There's a view that 70 to 90% of our patients will have a good to excellent result with early functional treatment, so why should we operate on them? And we think, although I will challenge this, that late reconstructive procedures are associated with good outcomes. But from these Scandinavian papers, if you operate on them, then they are considerably slower in going back to work. They also felt you got a better functional outcome compared to surgical patients. And once again, as you can see, this is going back with historic data, and also they may be stiffer. But that was kind of surgery back in the 1990s. Pischenberg actually compared functional management against acute surgery. And he said at the 8-year stage that he felt that on various parameters that you can see, that acute surgery was better than functional management. But surgery is still not great when you've got between 1 in 4 to 1 in 5 of your surgical patients still going over on their ankles. More recently, my friend and colleague James Calder at the Fortius produced this paper 6 years ago. He looked at 42 elite athletes who had had acute surgery in the first couple of weeks, and he followed them out to 2 years. And of those that obviously had very good rehabilitation, he said there was no recurrent instability. There was a 5% superficial infection rate, but the return to sport was 11 weeks for simple injuries, i.e. just pure lateral ligament injuries, but 15 weeks if you've got another injury, such as an osteochondral lesion of the talus. So it's not a quick route back to sport. So are there any circumstances when I think acute surgery should be contemplated? I think they're rare, but I would consider it if you've got an open injury, which has got to be cleaned to make sure you're not going to get infected. I'm sure many of you will have seen this kind of picture. You know, we've got a 45-degree opening angle here, and this is the larger avulsion injury. This may well be a very old injury that is still unstable in this case, or it could even be a congenital accessory ossicle. But the thing to note is the origin of your anterior talar fibular ligament is attached to that. And it doesn't matter how good your rehabilitation is, you're not going to stabilize that gap. Also, if you need surgery for other adjacent injuries like an ankle chondral injury, then you may decide to go early. But you need an experienced surgeon. What about going early, perhaps 6 to 8 weeks? I think you've got a high demand athlete, which is clearly unstable. If they've got this is an ankle arthroscopy, this is the talus, and this is the cartilage lifted up showing bare bone underneath that needs dealing with. You might think, well, I'm going to do both of those at the same time. What about electively? What will I do? Well, I think anybody clearly with recurrent mechanical instability that's affecting their day-to-day activities and sport. For the non-elite athlete, I really do believe they should go through conservative management for a good period of time because most will get better. If they've got a torn perineal tendon, if they've got unstable perineal tendons, they've got joint pathology, then we'll go, but they've got to be compliant. I would tell you that I think you need to be very careful with a patient who has got pain after their sprain, but they're not unstable. They're not necessarily going to benefit. I don't think they're going to benefit from lateral ligament reconstruction. Clearly, if they've got comorbidities, if they're not going to behave themselves, and you do see that number that I'm sure some of you have seen, that combination, they've got an unstable ankle, but they've got chronic sciatica, they've got, you know, L5-S1 nerve root pathology, and they're really difficult to get good results from. What do I tell my patients? Well, what do my patients want? Well, they don't want complications from surgery. They will happen in the best of hands. And I'm sure you're all familiar with those complications from operating around the ankle. They want to get their strength and balance back. They want to get back to sport as soon as possible. And once they've got back to sport, they don't want to be going over on their ankle again. They don't want to re-rupture it, and they don't want it to elongate with time. So that's what our patients are looking for from surgery. If you send your patient along for surgery, then what are they likely to be offered? There are dozens and dozens of different operative strategies. And if you go back, then usually it involves some kind of sacrifice of one or part of a perineal tendon. In 1991, I had my ankle ligament reconstructed using the old Evans, and I was a consultant in central London then. I can tell you in central London, there wasn't a single orthopedic surgeon who showed any interest in doing ankle ligament surgery. It was my own experience 30 years ago, that made me realize there's a lot of people who actually were having problems. You can take hamstrings, a bit like doing an ACL. You can use an allograft, but most people are going to use some form of Brostrom. What Brostrom talked about in 1966 has got nothing really to do with what most people do now. But what you need to tell your patients is that what you're going to do is like taking their double-breasted coat and you're going to tighten it up, a bit like an old open shoulder repair. And then you can augment it. You can take that free edge of the extensor retinaculum that we saw. I used the periosteum, that lining around the fibula, to produce extra support. I'm going to talk to you about using an internal brace as an extra stabilizer, and you can also sometimes do a brostrum with an old-fashioned perineal tendon combined. I think everybody should have an ankle arthroscopy first. There's a very high percentage of people, even with a negative MRI, who will have pathology inside, and that your patient may be offered an open traditional procedure, which I've done, but now people are doing minimally open and arthroscopic ligament repairs. Going back in the 1980s and 1990s, patients weren't very satisfied with surgery, and up to a third said they'd still got pain and recurrent instability. So that's where we were when I was just starting out on my consultant career. But of course, we do brostrums now, so we're all brilliant at doing them, aren't we? Well, we're not. Often by the time people get to surgery, they've got poor quality tissue. Beware that patient who's hypermobile. They may be large patients, particularly in sport. They may have those ossicles that we looked at. And of course, some of them come to us for revision. Nicola Mafuli, whom some of you may know, who's at the Royal London, he produced his paper 8 years ago, 42 patients, same number as James Calder, and he looked at them 9 years. Now look at this. This is an experienced surgeon. 8 years down the line, 1/4 of the brostrums had abandoned any sport, and 30% had evidence of arthritis. So there is room for improvement. The last 7 years, I've used the internal brace to reinforce my brostrum repair. There are others out there on the market, and I don't want anybody to think that this is the only one that should be used. But what it is, it's a fiber tape that is held with these biocomposite swivel locks that disappear after 2 to 3 years. And I was just going to show you the kind of thing, just very briefly, what we do. This is kind of the ligament reflected, and we tend to use these bone anchors. You may hear people saying that they've got bone anchors put in. These give a very, very strong suture holding position for holding the ligaments. It's better than just drilling a hole through the fibula. We then drill a hole for the internal brace in the fibula, and that's where after it's been tapped, you get your biocomposite swivel lock put in, to which the internal brace is attached. So all of that screw inside the bone is going to disappear. You then need to anchor it to the talus. Remember, this is only just over 1 inch long. Once again, you'll be tapping it after you've drilled it. And then you're going to use the anchors to tighten up your ligament. And then finally, over the top of your ligament reefing, you're going to bring the internal brace over the top. Let me just show you that just at the end. So the internal brace acts a bit like a car's seatbelt. It acts as a check rein to try and give you that extra instability. And I'll try and show you why now. If you remember earlier, we said that a normal anterior talar fibular ligament is only 160 newtons in strength. If you do a traditional brostrum, then when your patient gets off the operating table, the strength of their ligament will be only 50% of normal, according to cadaver studies. These were all done in Colorado. If you augment it with a hamstring allograft, then when the patient gets off the operating table, they will be equivalent to a normal ankle ligament. If you put bone anchors and the internal brace in, then you've gone 100 newtons over strength. And this is the reason that I do what I do. And I think you need to be very careful when you go for early rehabilitation. You want patients back early. They're not as strong as you think they are. So this is what I do. Sorry, but this is that anatomy that I showed you. This is the fibula. This is the neck of the talus. This would be the side of the ankle. So I put my internal brace in. I put my anchors in. I bring the capsule over the top. I actually mobilize the fibular periosteum, which is a very real layer, this sausage skin around your bone. I stretch that down, and I bring the inferior extensor retinaculum down. double suture it, and that gives me a really strong construct, which I'm very happy with. And when I first did this, this is the first patient that I actually did this augmented rostrum repair on. She was very interesting. There's a lady from Sheffield, a footballer, and I'd actually operated on a right ankle without an internal brace the year before, and I'd operated on a sister as well. And this was my surgical scar. And she came in at 6 weeks, and she said, I want to go back and play football because I think I'm ready. And she obviously wasn't ready, but it made me realize that this was a slightly different scenario in terms of post-operative rehab to that I'd used for the 30 years beforehand. So Gordon Mackay is a Glasgow surgeon who developed this particular technique, and Gordon and I worked together, and we've published our joint outcomes in various articles, which are all on ResearchGate, and I'll come back to that later on. So if anybody wants to have a look at those results. Well, let's go on to syndesmosis injuries. This is an ankle arthroscopy, just to orientate you. This is the lateral malleolus, the talus, this is the tibia, and in external rotation, you've got separation because the syndesmosis is gone. If you look back at rugby, pre-2011, it just did not appear in the Rugby Football Union audit. Following that, for the next 5 to 6 seasons, it suddenly went up and was in the top 5 match day injuries. So the question is, has it always been there, or does it represent a true increase in its prevalence? I think probably a bit of both. We're now more aware of it. A lot of the work for syndesmotic injuries has been done in the United States. And as you can imagine, it's been done in the military and also in the NFL. But this is an interesting paper going back to 1972 from Canada, American footballers in Canada. They took x-rays of them retired many years later, and 1/3 of them had ossification, calcification in their syndesmosis. So it is a much more common injury in high impact sport than we think. Just to remind you, there's 5 elements of a syndesmosis. There's the anterior inferior tibiofibular ligament. Underneath it is the interosseous ligament. Then around the back of the ankle, you've got these 2 ligaments here. And then going up into the shin, you've got the interosseous membrane. And basically, if you tear 2 of those 3 main ligaments, the AITFL, the IOL, or the transverse tibiofibular ligament, then you are at risk of some degree of instability. These injuries tend to occur mostly in external rotation. And the question is whether the foot is pronated or supinated. If it's supinated, then just a small injury will just tear the front of your syndesmosis. If the injury is greater, then you'll go on to fracture your fibula around the back of your syndesmosis and eventually damage either your medial malleolus or your deltoid. If you're pronated, then the injury pattern starts at the medial malleolus or the deltoid and goes around in that direction. So you can go from just having a little bit of pain and no instability to something that's grossly unstable. Now, these are the kind of injuries you don't really want to see on a Friday night when you're called into casualty. But this is quite clear. The syndesmosis has been torn apart, the medial malleolus is torn, and you're going to have a fracture up here. And if you have these kind of injuries, this is actually a low fibular fracture here, you're going to need to put a screw across to stabilize the syndesmosis, plate your fracture if it's there, and deal with your medial malleolus. So those are the ones that are going to finish up in casualty, coming straight to the orthopedic surgeon. How do we evaluate the syndesmotic injury? It is difficult, but as you probably all know, there are a number of evaluation techniques. I don't really find the cotton test well. That's when you take the hind foot and move it medially and laterally. The dorsiflexion ankle test and the external rotation of the ankle test, the Frick test, are really the best in terms of predicting longer recovery if they're positive. A squeeze test, I'm sure many of you do, is when you take the calf higher up and squeeze. Does it produce pain at the syndesmosis? You can do a cross-leg test when you actually get them to cross-leg their injured ankle over their uninjured knee, and does that cause pain? You can actually tape, as you can see here, around the syndesmosis and see if that goes in, that gives better stability. And you can also look at the length of tenderness along the syndesmosis as an indication of the degree of tear. So those are all the kind of tests that I would do. The grading system is, once again, from the military academy. It goes back over 24 years now. And like other injuries, it talks about grade 1, grade 2, and grade 3. And it really depends, these three important ligaments, how many of them and how completely they've been injured. But at present, I think it's fair to say there's no decent classification in existence that really guides our treatment and predicts outcome. This is what you can see on imaging. I hope you can see this. This is an MRI scan. So this is a normal anterior inferior tibiofibular ligament seen in a cross section. Just to orientate you, here's your perineal tendons, here's your Achilles, tibia and fibula. This is a grade 2 injury. You can see it's intact, but it's thickened. And then this is your grade 3 injury where you've actually got a complete tear across it. There is a good place for CT scans. You can pick up subtle little fractures like this one at the back. Here's your fibula and your tibia, to which the posterior elements will be attached. And also, if you think that the syndesmosis injury has caused a malreduction of your fibula, you can scan both ankles at the same time. You can see the fibula is neatly settled into its groove in the tibia there. Clearly there it is malreduced. So a CT can sometimes be very important. ESCA, who are the European Society of Sports Surgeons, have had this consensus: acute, subacute, 6 to 6 months, chronic. For the acute, the stable ones, then they can really be treated with conservatively. But what I would say to you, and I'm sure many of you have treated these, if you've got a combination of a syndesmosis and a lateral ligament injury, that will double your healing time. It's very important that the athlete understands that straight away. The latent unstable one is the most difficult one. I'll come back to that in a second. The one who is frankly ruptured, that some of those x-rays that we saw, they're going to need open reduction. These are going to need stabilizing and with a screw like we saw, or we'll come to the suture button. And quite often they're going to need removal of the implant at second surgery. So it's those which you may consider going for the operating theatre. Where have I found problems in the last 20 to 30 years? It's my elite athletes, the sports physician or the physiotherapist from the club brings them along. They've had their high ankle sprain. They've been rehabbed very well. They've got to 8 to 10 weeks. They don't think there's instability on the scans, but it's still painful. And the patient just doesn't really feel it's stable. So what do we do now? You really do need to do an ankle arthroscopy. Once again, to orientate you, this is the talus, this is the tibia, that's the lateral malleolus, and these are torn, bleeding fibers of the syndesmosis falling down into your ankle joint. And this is more likely to lead to a diagnosis than any form of scanning or radiography. Your options are to use the screws that we've seen. The trouble is they often break, and often that you'll take them out over a couple of months. This is the tightrope, which you can use 1 or 2. This is an ultra high molecular weight polyethylene. It was with these buttons on, which bind it together. And of course, they're not quite as difficult as screws. They're going to have a little bit of give in them, and they're not going to break on you. And then sometimes the Americans will use a combination of screws and suture buttons, and then the internal brace, which I'll come to. This can all be done percutaneously, i.e. without opening it. The tightrope has been around for over 20 years. It was invented by a junior orthopedic surgeon in Ireland. It's made him a very rich man, and is used all over the world. In the last few years, the internal brace has been added to it, so you can put your tightrope in. If you've got a fracture, you put a plate on, but then you augment the anterior inferior tibiofibular ligament with an internal brace. And this, in my practice, has allowed me to rehabilitate my patients quicker. Now we're going to come finally, and hopefully we've got too long, and we're going to talk about the medial ankle, the deltoid and the spring ligament. These are rarer, and I think most people, whether they're orthopedic surgeons or rehabilitation specialists, feel less comfortable. The anatomy, if you remember, you've got superficial and you've got deep structures. The superficial structures are the tibionavicular, the tibiospring, and the tibiocalcaneal, and they span two bones from the medial malleolus of the tibia to the navicular and the calcaneum. If you lift those up, then you've got your deep fibers there. Now, and the deep fibers only span the tibia and the talus. The spring component really should be thought of as merging with the spring ligament itself, which comes from this part of the calcaneum, the sustenaculum tali, and I'll come back to this, and it comes under the navicular. If we look at American football, this was an interesting study. 1 year, 320 players coming in just below the NFL, 72% of them injured their foot and ankle, and just over 1 in 8 required surgery. 2% of the players had a deltoid injury, where 31% had a lateral injury. And interestingly, they'd only got 7 injuries, but all of them were on the offense. So that's the idea of the relationship. About 8 years ago, I tried to classify my deltoid ligament injuries in a publication. The acute ones, the isolated deltoid injury is unusual. Obviously, most of them associated with ankle fractures, but increasingly we understand these combination injuries of the deltoid with all the other injuries. In terms of the chronic injuries, they're secondary to acute injuries, but also you get these combination injuries with the insufficient tibialis posterior tendon and the spring ligament together. And we'll just go and talk about those. The combination ones, if you look carefully, Beat Hintermann in Switzerland, a friend of mine, showed that of those patients with instability laterally, 40% had a deltoid injury. On MRI scan, 3/4 of patients requiring a brostrum also had a deltoid ligament injury. And then we've got papers showing multi-ligament rotational instability. With the deltoid ligament, always think about the syndesmosis, because as we've seen, they go together with external rotation injuries. And with the spring ligament, you often get a combination of spring ligaments and superficial deltoid ligament injuries going together. So don't just think this is an isolated deltoid injury. They usually go with something else. Your patient will come along with an acute injury. Sometimes a few weeks later, you just may see this telltale sign of resolving bruising, and the patient will have said they felt this pop, pain and swelling. But in an orthopedic practice, they usually come much later. They'll tell you about the original injury. The Americans talk about this instability when they're running the curve, kind of when they're bend runners, particularly if it's their right ankle, and they'll get medial gutter pain, and the tibialis posterior tendon comes under stress. If we image it, then we may find in the acute injury, obviously we see the fracture and we see the deltoid, and sometimes these deltoid ligament injuries, they rupture mid-substance and they actually infold into the ankle, which causes a problem and they need fishing out. In the chronic stage, then they'll open out on stress x-ray, and they will very rarely open out like a lateral ligament. Only a 5-degree opening compared to the other side is usually an indication of chronic instability. And then, of course, you'll have your MRI scans like this one, which shows the deltoid ligament injured and also affecting the bone to which it's attached. So what are your management options? Well, acute full tears usually go with fractures and they need urgent surgery. For elective ones, then grade 1 to 2 deltoid ligaments would usually heal with conservative treatment. If you've got a complete rupture with clinical and imaging proven instability, then they need to go for surgery. And you've got to consider if other measures are required, and we'll come back to that. And always have your antennae up as whether this is multi-ligament pathology or whether there's something going on in the ankle. If it's acute, then you can suture your ligaments, and you may have to deal with your fractures and your osteochondral injuries. In the chronic stage, once again, you can repair it rarely, but you tend to do a medial brostrum, which is really to take off the ligament from the medial malleolus and pull it up, and then anchor it as you do on the lateral side. And then once again, we can augment it with an internal brace. Before we had the internal brace, we're going back 20 years, I actually split tibialis posterior tendons and rerouted it into the medial malleolus, and you can use allografts. If you've got a patient who's beginning to collapse their ankle and they're starting to get a flat foot with a valgus, then you may have to do an osteotomy as well. The spring ligament is very topical at the moment. This is the last thing. There's a lot of discussion about the spring ligament, and I've tried to add to it as well. When you're talking to your patients about what the spring ligament is, tell them it's a hammock. It's the hammock that sits under their midfoot medially, supporting their talar head and their navicular. And it's got three components: this big fat one that comes, the supramedial one that comes from the sustanaculum tali. There's the smaller inferior plantar one, and then there's the third ligament. But this is the one that normally gets injured. Spring ligament injuries, most of them will be in association with tibialis posterior pathology. Isolated injuries are rare. There's still case histories. There is no orthopedic surgeon who will give you that I've got 50 acute injuries and this is what I've done with them. It is still relatively rare in the literature. The acute injuries are usually pronation injuries with the medial swelling, bruising, and tenderness. And the problem is really trying to sort them out between tibialis posterior injuries and spring ligaments. And there's a question now of what comes first, the chicken or the egg. Is it the tibialis posterior tendon that goes, or is it the spring ligament? But the patient will complain usually of pain in this area here. And if you think, is this a tib post or is this a spring ligament in isolation, then you know that if you ask them to activate their tibialis posterior tendon, they won't be able to. But if they're able to activate it, and then as soon as they relax, it collapses again, then think, is there a spring ligament rupture here rather than a tibialis posterior pathology? Ask them to do their single stance tiptoe, look whether their heel comes out of valgus, all of the usual things that you'll do. This is what the MRIs look like. This is the inferior ligament. This is the intact third ligament. This is your big, thick supramedial ligament, and this is your tear. This is seen looking up underneath. This is the side view. They almost always have bone damage on the undersurface of the talus, and you can see this is a partial rupture. This was in an alpine skier that came to see me. What are our spring ligament injury management options? Well, untreated acute tears will lead to progressive deformity. Minor tears, partial tears with no deformity, I think can be considered for cast immobilization and then rehabilitation. There's little place, in my view, for conservative treatment of that rare complete acute tear. A simple repair is unlikely to be sufficient because the tissue is going to be so poor. But we still don't have definitive papers on what the ideal surgical reconstruction should be. But once again, most surgeons now are using the internal brace. We anchor it into the os calcis there in the sustanaculum tali. We part it through a drill hole in the navicular, and so it acts like a hammock. So that is the way that most surgeons are now rebuilding or reconstructing the spring ligament. So finally, thank you very much for mentioning the book, Knife in the Fast Lane. It's 40 years of looking after sports people. It's where we were in 1981 when there was no care to where we are in 2021 when you might argue sometimes they're pampered and overcared for. But it's been a very interesting surgical journey over 4 decades. I'm very grateful to all my rehabilitation specialists. They always say a great physiotherapist can make a poor orthopedic surgeon look very good, and I've always remembered that. As we said, that book, Supporting Prostate Cancer. So thank you very much. I'm very happy for anybody to email me. Go to ResearchGate, you'll get my papers on the subjects, and thank you very much for listening to me, and I hope you found it useful.
Wonderful. Thank you, Bill, and thanks for posting the contact details there as well, because that's always one of the questions that floods in when I get to the end of the Q&A and I haven't asked everybody's questions. The first thing I wanted to pick up on is we touched on arthroscopy a couple of times as a diagnostic tool. I've got 2 little questions around this. So one, what proportion of your patients would get arthroscopy diagnostically? And following that, do they only get it once you've already decided they're going to have surgery and you just need to see what they're going to have? Or can it be used to decide between conservative and surgical?
Well, the first thing to say is that although, my passion is foot and ankle, I'm still up until my retirement, was still a knee surgeon as well. And you do far more knee arthroscopies in my practice than ankle arthroscopies. And I was glad I did knee arthroscopies because it made sure that I was still a good ankle arthroscopist. We touched upon the need for doing an ankle arthroscopy as part of your ligament reconstruction, because you will see a lot of pathology in there that you've not picked up on scanning or clinical examination. So I do think it's important. However, there are points when you're not quite sure. And this is where really, I said I'd be very careful about the patient who's still got pain after their ankle sprain, but it doesn't look to be unstable. You might have scanned them, you've done an ultrasound, an MRI scan, and they've got thickened ligaments. You might have done a steroid injection to try and reduce it. But sometimes if you do an ankle arthroscopy, you may see other pathology. I didn't mention a Bassett's fascicle, which is thickening of the bottom of the syndesmosis anteriorly. You can't really see it on scanning, but this is a prominent cause of anterolateral ankle pain. And it's a very simple thing just to go in and shave it down. And you just can't see that on imaging. So for all of you out there, if you've got a patient, you're not quite sure, and they've got pain anterolaterally in that lateral gutter, just think about whether they've got a scarred bottom of their syndesmosis, their AITFL, and that's when they need their arthroscopy.
Great stuff. Right, we're gonna get into the questions. So Martin's first up.
Do you want me to take my screen down, or?
No, you can leave it up because people get the contact details. That's great. I'll replace it with mine in a little bit. But, so Martin asks, with the rostrum anchors and internal brace given 100 newtons more strength, does it limit the range of motion?
Well, the important thing, and I learned this very early on, the anchors are not going to affect, because basically when you're doing your rostrum, you've got to get some anchorage on the bone to pull up your ligament and take the slackness out of it. And prior to anchors, what you did was you did 2 drill holes. You came out the other side of your fibula into your perineal tendon canal and sutured it. And you can imagine that was a bit of a fiddle and not very good. So the anchors are just give you a really strong hold. You've got to be really careful with your internal brace. And it's a good question, because if you just use it as an excuse for doing a poor rostrum, and you just tighten the bejeebers out of it, then you will finish up with a stiff ankle. It's designed to be, as I said, it's designed to be just like your seatbelt in your car. It shouldn't be holding you tight all the time. It should be there just to hold you if you just go over that limit. Because if you make it too tight, then you'll get stress shielding and your ligament will not regain strength.
Bro, and I think we've probably touched on part of the answers to Iona's question here, because it's another question on rostrums. A patient of hers had a rostrum internal brace 6 months ago. He's now struggling with virtually no inversion range of motion, which he realizes is kind of the point, but he gets pain when on an uneven surface over the repair area. Is that normal at this stage? So we're 6 months post.
At 6 months, it isn't. And just going back, if it is really that tight, then clinically, then there is a risk that it was over tightened. One of the problems with the more historic repairs is that they tended to get slack with time, and certainly I can tell you mine did. So that's really what you're trying to offset. But my feeling is if it's painful and it just feels very tight, then it probably has been over tightened. Although it's not very nice for the patient to contemplate, if the internal brace has done its job and the lateral ligament is now beefed up enough, then just going in and just just dividing the internal brace would probably improve things significantly, and they don't have to go back to square one because the ligament's been repaired. It would take me an awful lot to do that, and I would tell the patient to hang on for at least a year. But that may be necessary if it continues to be painful and stiff.
Yeah, I guess it depends to what extent it's affecting quality of life, ADLs, return to sport, etc. Okay, this one just jumped up to the top with some extra votes. So what's the best, most effective test for differentiating between deltoid ligament injury and spring ligament injury?
Obviously on your history, you need to know kind of exactly where their pain is. It's going to be just for the deltoid, as you appreciate, the maximum area of discomfort is going to be just at or below the medial malleolus, whereas for the spring ligament, the pain is more actually under the navicular. So we're all familiar with finding the navicular tuberosity and where the tib post attaches. Then usually spring ligament pathology will be found just under that, because the spring ligament blends with the tibialis posterior insertion. So deltoid tendinous pathology just inferior to the deltoid and the medial malleolus. The spring ligament's going to be underneath, and then really it comes to your instability tests. When you're undertaking kind of a valgus test with the ankle kind of held in neutral and then bringing it over, do you get that feeling of the ankle opening up? And if you're not sure, then I still, rather old-fashioned, I will go and do some stress testing. Whereas a pure spring ligament injury, that test I showed you from Hinterman, to ask them if they can activate their tibialis posterior tendon, and if that reconstructs their arch and then collapses again, then if you see that sign, that's an isolated spring ligament injury.
Real cool. Lots of questions going in now. Everybody's got confident. Steve, it's quite a long one, so bear with me. Can you speak to injuries of the perineal retinaculum following high ankle sprains? He's a patient that's had significant high ankle sprain, which in large part has resolved, i.e. he's had a full return to work and sport. At rest, however, he's experiencing significant tightness in the ankle, which requires movement into eversion to relieve. He gets a significant pop-in during every eversion movement.
Right. Perineal tendon injuries, that's another complete lecture. Once again, the Swedes ones.
Perineal retinaculum he's gone for, sorry. Yeah.
Well, obviously the perineal tendons are inside that perineal retinaculum. So perineal tendon and perineal retinaculum pathology are very commonly associated with lateral ligament injuries. They frequently go together. And if they're getting a kind of a tightness and a popping, then, and presuming it's not unstable, but it's, the perineal tendons are not coming around the fibula, then you really do need to do either an ultrasound or an MRI scan. One of the most commonly missed pathologies, and it is so much more common than you think, is anomalies of the perineal tendons. The first is that you have a low-lying peroneus brevis, that the muscle belly of peroneus brevis goes all the way down to the tip of the lateral malleolus, and that causes pain and it causes problems of swelling in that area. Also, it is not uncommon to have a third perineal tendon coming down, which also causes problems. And about 25% of us will go to our graves with a split in the perineal tendons that we're not aware of, but which can often show up on scans. So I think if there's a feeling that there is a problem with the perineal retinaculum and the tendons, that needs to be looked at. You can have rarely injuries when the perineal retinaculum lifts off with a little piece of bone as well, and that frequently gets missed and can cause pain. And you can see a flex sign just on the plain X-ray.
Great stuff. I'm conscious of time. I'm going to do one more question. Abigail, I'm very sorry, I'm going to skip yours because it's on Achilles and we've not talked about Achilles tonight. It could be a whole presentation on its own.
I'm quite happy to talk about the Achilles.
but because we've not covered it in the presentation, Abigail, I'd maybe send that one to Bill as a follow-up question. I'm going to go for this one. So, how common are talus fractures? And I'm assuming we're talking avulsion fractures, given the presentation. How common talus fractures? Which ligaments are most likely to be involved, and how are they best managed?
Okay, well, as many of you know, getting either a neck or a body fracture of the talus usually requires a considerable amount of force, and they were first described during the First World War, when the Sopwith camels used to come down and basically the floor came up too quickly and went straight into the hindfoot and caused talus. So they were known as aviators astragalus. And the talus has a very, very poor blood supply. The talus is a bit like the scaphoid in the wrist. It has a very poor blood supply and heals badly. And that is bad news. If you're talking about associated ligament injuries, you saw that MRI scan I showed where you got bone edema either side. It's very rare on the lateral side to see a talus injury at the insertion. I don't think I've actually ever seen it of the ATFL. On the medial side, the deltoid, you do see flake avulsions where the deep deltoid ligament attaches to the medial wall of the talus and pulls off a bit of bone. And those can actually be quite painful, because one you don't often see, they often get missed initially on a plain x-ray if they've had one. By the time they come to you, the whole thing's embedded in scar tissue, and the avulsion is usually healed proud from the wall of the talus, and it's very painful, and they've got medial gutter pain. So usually you'll start off obviously with rehab, you probably will inject it, but there are rare cases when you've actually got to go in, lift up the talus, pare off that bone and put the deltoid back down again. But they are rare, they're rare circumstances.
Excellent. Thank you very much. There are quite a few more questions. I'm going to encourage people to send them to you after the talk, because I am conscious that we have run over a little bit, and I don't want to keep people for too long from their evening. I'm going to just throw my slides back up, and I don't know if you want to come back in as well, Andrew. First of all, just to say a huge thank you for giving us your time this evening, for giving us your knowledge and expertise. I'm sure people have taken a lot from this evening. Lots and lots of stuff to go away and think about and apply clinically, and certainly a good refresher on ankles for me, and a good update. In terms of housekeeping for everybody, you'll get directed to a survey automatically after this. We'd really appreciate your feedback, comments on this evening and reflections. It helps us to improve the events in future, and of course we'll pass all your feedback on to Bill as well. So if you've got some nice comments to leave for us, that'd be great. We'll email you all the information, including your certificates and a link to the recording for this evening. You'll get that tomorrow. Please be patient. We will send it, I promise. We'll also include the contact information that Bill's given us, and a link to buy his book, Knife in the Fast Lane, which I'll certainly be doing. You can follow Basrat on basrat.org, and you can on Twitter, and you can do the same with Steroplast, and join our group on LinkedIn if you want to stay up to date. Andrew?
Yeah, thanks, Ollie. Thank you very much, everyone, for joining. Great to see so many good questions again. And obviously, thank you ever so much, Bill, for your time and for sharing a lifetime of, well, a snippet of your lifetime of expertise. So, yeah, always fascinated by the level of knowledge that surgeons have, and yeah, really appreciate you sharing that. And I'm sure, like Ollie said, it's been very useful. So yeah, thank you very much, and yeah, I hope everyone's found it useful. I'm going to carry on reading the book, and would definitely recommend that everyone else does the same.
Yeah. Okay. Well, thank you very much. I apologize if it was a little bit long. You know, the problem is when you have a passion about something, but I hope people took something away from it that they found useful. And please get in touch, email me. I'll be spending the weekend in London examining in anatomy for the next 4 days. So if I don't get back to you till next week, I do apologise, but I'd love to hear from anybody who wants to talk to me.
Bill, I don't know if you can see them, but if you've got the chat open, there's loads and loads and loads of really nice comments in there, and people thanking you, which is great to see. So